So welcome. My name's Elaine Gilbert. I'm a pediatric psychologist, and so I specialize in the medical overlay with psychology interfacing. And so I do a lot of behavioral interventions as well as cognitive interventions. And I really kind of live in this in-between world where nothing's all in our head and nothing's all physical, but the head's connected to the body. And so we need to treat both as holistically as we can. So today I thought I'd talk with you all about adaptive coping strategies for parents and youth. And much like Dr. Rao, if there's any questions along the way, please just throw a hand up or shout out. I want it to be really informal. So disclosures. I'm going to be presenting on a lot of information from the Children's Health and Illness Recovery Protocol. And it's a manualized treatment program that we use for both children and teens coping with chronic medical conditions. And it's a range of presenting issues that we often see, bless you, rather it be from cancer, transplant, autoimmune hepatitis, or whether there is chronic pain involvement. So we see that this protocol has actually been studied and helpful for all of those conditions and more. So hopefully we find some help and some structure through that. And so objectives are really just that we can talk about some different coping strategies that then you can take them home, apply them to everyday use, and then we can just start talking about communication and how we can start collaborating openly and honestly with one another. So I really like this kind of table format to help us structure the session today. And so when we think about overall functioning of both children and teens and even of adults, there's a lot of domains that are going to interface with one another. And I think it's important to try to highlight all of those. And so we have both our kind of physical outlets as well as school, which is a big component. And we're going to touch briefly on some accommodation outlets for that, as well as just personal functioning, how we're doing psychologically, how we're doing socially, and then interfacing all of that with lifestyle management tasks. And so I think it's important when we start talking about chronic disease management that's stressful in and of itself. But not all stress is created equally, and oftentimes stress gets a really bad name, and there are good stressors in life. And so at times, I like to take a time out and really identify where the stress outlet is coming from. And so we have our internal stressors, which are the stressors that are perfectionistic thinking, are our anxieties, our worries. More of the internal self-talk is where that stress is coming from. And then we also have our environmental stressors. So environmental stressors may be school, social, family stressors. Those are different environmental outlets, right? And then there's the physical element, and that in itself, having a chronic medical condition can be stressful. And so while coping may be going great in all these other domains, there's this constant stressor that may be contributing to some difficulty or some maladaptive cognitions along the way. And so I really like to kind of ground in those areas and then think through what that stress can help contribute to. And that good stress actually can be very motivating and can facilitate change in some ways, while bad stress may also be able to facilitate change, but it's all within context. And so, not to bring back flashbacks from school for anyone, but a bell curve is also a way of discussing stress. And Yerkes-Dodson developed kind of the stress hierarchy, in that we see that too little stress, we're kind of just unmotivated, there's no change, we're really not seeing any development or any behavioral indications. Where then too much stress on the other end of the continuum is paralyzing, fearful. We can't really do much with it. It's like, I'm stuck here and I'm not gonna move. Where then we see an optimal range of stress can actually be really helpful and can facilitate some of those behavioral outlets. And so I like to talk a lot with especially teens about where are we at on the stress continuum. Because if we're all the way over here, we need to address stress right from the get-go. We need to identify the stressor and talk about some strategies to lessen that stress so that we're not paralyzed by it. Or if we're on this other end where it's almost learned helplessness, like I can't change this, I can't do anything about this, then we need to talk about some motivating factors and some control pieces to help encourage and facilitate change.
That's an amazing graphic.
Yeah.
I love that, because there's a pain scale that we all know what that looks like.
Yeah.
But a stress scale is basically what that is. And that is
Yeah.
so cool, because it's really hard to talk talk to your kids about, are you stressed? Like, I mean,
Yeah, because the answer I always get is no.
yeah.
Or on the other end, yeah, duh, right?
But that's really great.
Yeah, and so like I'll just draw the bell curve, and of course kids are like, listen, I got a C, okay? You know, it's like, okay, wait, that's not what we're talking about, the grades, because teachers will grow all this all the time in like biology courses and things. But I have them just mark, where are we at? Like, what do we need to focus on, or what do we want to do? And trying to help them transition. And sometimes we're starting to fall close to the edge, so how can we kind of take something off our plate?
Well, and it says that is not good. Like, you know, it's hard to know where
Right,
to judge.
exactly.
But when you see somebody's on that right side of the curve,
Yeah,
they can visually say, okay, I get it. That's not where I need to be.
right.
That's cool.
Yeah. And so kind of transitioning into what can we do? What are the outlets? And how do we really encourage adaptive functioning despite having chronic medical conditions going on in the background? And one thing that we often find is that physical activity is greatly impaired. And at times there's a lot of deconditioning that's involved in that. And when I say physical activity, it's not running. It's not running a marathon. It's not, swimming across the ocean. We really want to ground in adaptive physical activity and making sure that it's fun. Because if it's not fun, they're not going to do it, right? I wouldn't do it if it's not fun. And so I often talk about this as a very foundational piece of what we do in our program. And we're simply trying to come up with different outlets and different ideas and modalities to engage and to encourage that activity piece that we know is helpful for mood as well as just overall physical health. And so I go through and often highlight kind of like a strategy of how we're going to attack physical activity and set up a goal setting format. So choosing a form of physical activity. Oftentimes people are like, I'm not running. Great, cool, you don't have to run. Let's talk about walking, or let's talk about swimming, or let's talk about something that you're engaged in. Let's go to the playground. Coming up with activities or ideas of what form of physical activity. And we often do this on a weekly basis and really trying to switch it up at times if they become bored or if it's just not something that they're wanting to be involved with any longer. And then we describe the level of engagement, and that is really trying to quantify the goal. Is it going to be 10 minutes of activity? Is it going to be 5 laps around the house? What is going to be that norm? And again, setting the realistic goal, because we don't want this to become something that we don't think is achievable. For it to be successful, we want them to be able to see that they can attain this goal so that then we can build on that scaffolding approach so that the next week we can take 2 laps around the house versus sitting on the couch all day. And then schedule it. So this is often the thing that I find is really helpful, is having that accountability and finding and carving out the time. Once things become a consistent part of your schedule, you're more likely to engage in them. And then the doing it. While in some cases maybe the quote unquote easy part of this whole setup, right, if you have it scheduled and you're there, but really trying to then encourage and praise when that occurs. And that's when then celebrate when you do meet your goals. And that can be anything from self-care of taking a bubble bath or, going to a movie, trying to set some goals, but then celebrating the successes along the way. I think something that's also important when we're thinking about just overall coping strategies is sleep. And I'm not going to hammer it home too hard. I know that we all talk about it. But things that I often find is, and we live in a technology age where everyone's got a cell phone, right, at all times. And we're plugging our cell phones in our bedroom and we're charging them and we're looking at YouTube videos or watching Netflix well into the night. But what the research is telling us is the blue lights and the screen time is actually very harmful for overall sleep quality. And we know that sleep is so restorative and reparative. And so really trying to set some structure and some standards in place for the bedroom and the sleep time. We want the bedroom to be a conditioned place of sleeping. And so in order for that to happen, we often say, hey, come up with a family docking station and put phones on the kitchen table and have everybody plug in, make a nighttime routine. Now for teens, it doesn't have to be elaborate. I'm not saying you have to take a lavender bath and, pick out clothes and everything. But what I could suggest is brush your teeth, wash your face, put your phone on the charger. Right there, now we already have maybe 10 minutes where you're phone free and light free. And trying then to condition the bed in and of itself to be a sleeping place. I find that a lot of, especially teens, but also children will do homework in bed. They will watch Netflix in bed. They'll watch television in bed. What's happening is we're conditioning the bed specifically to be in place of anxiety or of arousal, and we only want it to be associated with falling asleep. The more we can associate it with falling asleep, the quicker we're going to fall asleep and the more maintenance we can have in the sleep. And some of the other strategies are just keeping a cool, dark room and some of those other ideas. So now comes through when we actually are kind of have some of these standards and these foundational pieces in place, is really talking about how do we cope with stress overall, whether it be the internal, the environmental, or the physical realms of stress. And so one of the key factors is deciding whether or not we have control over the identified stressor. And if we do, then that navigates us to a problem-solving modality. If we don't, or if we have tried the problem-solving modality and there was little to no change, then we're navigated more to the managing the impact of that stressor. The problem-solving modality, and these are both active strategies, I should say. We're going to talk briefly in a couple minutes about more of a passive strategy, but I really wanted to touch here first. And so the problem-solving strategy for stress is that we identify the problem, we then brainstorm. Now, when I say brainstorm, what often happens is we automatically already pick what the solution should be and will be, without allowing ourselves the freedom and the space to really think through what are our other options. We don't want to weigh pros and cons. We don't want to make a decision. We want to allow that freedom, whether or not a child is doing this with a parent through guidance, or whether or not a teen is doing this alone, really trying to foster, hey, right now we're just going to throw all ideas on the table, even the silliest, the dumbest, whatever. And sometimes I even throw ones on that are a bit provocative. For instance, like, you could not take your medicine if we're talking about medication. It's an option. And sometimes we need to throw that on the table to then hear and elicit the motivation, right? But also then, the next step is to then weigh the pros and cons of each potential option in the problem-solving modality. And then the fourth and final strategy is to pick how you're going to cope with the problem and what you're going to actually do from a behavioral standpoint. Then you reassess. Potentially it wasn't that you picked one option, but two of the solutions that you had brainstormed. Then reassess and think about what you've learned and gathered from that. It's amazing how many times we don't stop and actually think through what options we have in problems. And so sometimes just taking 5 minutes and thinking through, okay, what options do I have, and briefly going through the problem-solving modalities in our head can be really helpful. The second strategy, when either we don't have control, like I mentioned, or when we've tried problem solving and there's been little to no change, is managing the impact. And I kind of describe this as to my kids as, hey, we're going to put on our armor or a rain slicker, and we're going to really manage this right now because we don't have control. And when we think about everything that goes on in our daily life, we actually have very little control over what's happening. And so these are more the strategies of, hey, let's work on relaxation. Let's work on managing yourself and taking control back over of what you can do within your body and yourself. And so relaxation strategies that I often encourage and talk through and model are diaphragmatic breathing, which is your simplistic belly breath. A lot of people are taught this, but I don't know if they're necessarily taught the science behind it, right? And so the reason why diaphragmatic breathing or deep breathing is helpful and important is that we're actually starting to regulate our body. So we have two different systems. We have a parasympathetic and a sympathetic system, not to throw big words at you, but the parasympathetic is the system that's going to calm your body, while the sympathetic is your fight or flight. So think about a bear chasing you, sympathetic's on. We're not eating, we're not doing anything but running, or flight, fright, or freeze, okay? Where the parasympathetic is kind of our parachute down. We're calming the body down. And so oftentimes when we're stressed, or really stressed, our sympathetic system is firing. And so we have increased heart rate, we have increased respiration. Our temperature actually is lower because our body is constricting our blood vessels, and we're focusing all blood flow internally in our organs. And so what we do is through the breath rate, we're actually controlling the body and kind of reinforcing that homeostasis, or allowing it to calibrate and encourage the parasympathetic to help us out. And so the breath rate is helpful when we think about breathing in through our nose, out through our mouth. We're cycling the breath, and we're lengthening and deepening the breath. Now again, if I were to kind of show you all, I would think, okay, I'm going to go in through nose, out through mouth, and try to extend the diaphragm. So if I had hand on chest and hand on belly, the hand on my belly is going to be the one that I want to push out. So I can breathe in and out. And so we're going to lengthen the breath. Even then I got a little like, okay, here we are, we're here, right? And so I would encourage 10 to 20 breaths. And what we're doing is starting that system. We're starting that parasympathetic system to come into play and help us out. The next is progressive muscle relaxation. And that's when we're going to tighten muscles and then relax them. I usually have people hold for 5 to 10 seconds. And with like my little ones, I'll give the example of squeezing lemonade with our fist. So we're going to squeeze as hard as we can and let the seeds pop out and the juice fall down our arm. And then we're going to shake it out, right? But you can do it from toes all the way to head. And it's a great way to strain the muscle, but then allow blood flow back into the muscle. Some strategies for belly breathing for little ones, because I know that there were a lot of little ones in the room. I often use bubbles as a great way to reinforce and encourage slow, steady breaths, or pinwheels are great ones. Also, I like food a lot, so I like to use different modalities, and it encodes it in our olfactory senses as well with smell and taste and everything. So if you use like cookies or favorite desserts or favorite warm foods, you can smell the food and then blow on the food to cool. And then, of course, you get to eat the food. Go ahead. Oh, I didn't know if you had a question. Then the third strategy I often use is guided imagery, which is creating that safe space and really walking through with your imagination, whether it's a fantasy or a real place or any combination, exploring all your different senses and allowing yourself to really kind of create the new norm for yourself and your brain. So then we bring into this component, those are all behavioral strategies, and so we want to think more about the cognitions that may be associated with this. And as a psychologist, we often look at this overlap of how our thoughts affect our emotions, which affect our behavior. And so if I were to give you all an example, if you'd walk outside this room, you would find a $100 bill on the ground. What would be a thought that somebody would have? Just a thought. Sweet. What is an emotion? Ah, good. What's the emotion with that? That's a thought. Yeah, happy. Okay. And then what's the behavior? What are you going to do? Pick it up. Okay. And so then all of a sudden you see somebody running down the hallway. Wait, stop. Now what are you thinking? Dang it. What are you feeling? Disappointed, perhaps, sad, frustrated, right? What are you going to do? Give it back to him. What did you say, run? Yeah. And so I always like this with my teenagers, a little bit of a morality test as well. So they get to you and they say, oh, thank you so much, you found my $20 bill. Now what are you thinking? Hopeful. Okay, maybe a feeling, right? Maybe hey, wait, I have 100, right? So maybe hopeful feeling, maybe suspicious as a feeling word. And then what's the behavior?
Just really confused.
And it's like, do I give it to you? Do I turn it in? What do I do? And so what that does is it tries to paint a picture. And I use that example often with teens and kids to talk them through how those all are actually connected, but we skip over them. And our brain is meant to take in lots of information at once and to have kind of semantics or models of what we do and what we should do. And we skip over oftentimes identifying the thought or the emotion that led to the behavior. We're just acting. But sometimes that can be faultful. While it's really efficient and a great way for our brain to make use of things, it also can become problematic, especially when we're thinking about maladaptive cognitions or thought traps that our brain sometimes gets stuck in. And so I like to think through this from a medical perspective at times, because I think we, both as clinicians, as parents, and even as teens and kids, we often have these, and they're automatic. Everyone has them, just to normalize it, but we sometimes have to identify them when our brain keeps getting stuck in these modalities. I'm going to step on this side for a second. So some are like hopeless thinking. This is never going to get better. I'm never going to get over this. Catastrophic thinking. I think of that like kind of as the tornado or the drain spout, where you're just kind of unraveling, where my head hurts and I must have a brain tumor. Or perfectionistic thinking, which is, that very rigid mindset of having to be perfect. Exaggerations, all or nothing, or black and white thinking. There's a lot of gradation in the world, but our brain often thinks too, this is all good or this is all bad. It can't be any in between. Assuming the worst, so that's really assumption reading, right, and predicting the future. A lot of times teens will do this with teachers or parents, And so it's helpful to think through. Nominalization, which is like, I did poorly on that assignment and I'm so stupid. So we're kind of misattributing that you did bad on one assignment, and therefore then you're jumping to the conclusion that that has to do with your self-worth. Blaming thoughts of, it's all my mom's fault because I had this, or it's all my fault as a parent that my child has this. And really thinking through how often we're having them. So the first step is really to identify and to think through that we often don't realize how frequently we're having these thoughts or these different thought traps that are stumping us or that we're falling into. And so the first step of cognitive behavioral therapy is to identify how often these are happening, and then to identify the emotions that may be happening with them. And for little kids, it can sometimes be as simple as like, well, I don't know, today is the worst day ever, right? So my example can be both for teens and or little ones, but this is the worst day of my life, okay? And so we would identify the thought that was automatic in and of itself, and then we start to weigh the facts that support and the facts that do not support. So facts that support, when we start to go through, are in pain, I missed a field trip, and have to go see the doctor. That does sound really stinky. That does sound like a bad day, right? Now we talk about the facts that don't support it. And this doesn't have to be written out in this type of modality. You can do this verbally with your teens or with your kids or with yourself, but sometimes it's helpful just to see it written. Facts that do not support. I have been through worse. I like my doctor, actually. They give me stickers there. Maybe they can actually help and I could feel better. My parents are home, so I get to spend the day with them. That's pretty cool. I got to watch a movie on the way there, and my friends text me to check in to see how I was doing. So is today the worst day of your life? Or is there an alternative thought that may be more appropriate and more true to how we want to clarify or identify that? So maybe today is a hard day, but I can make it a better day by doing some of these other modalities. And so really working through to restructure those and catch ourselves when we're having them, right? And then we talk some, and I'm just going to touch on this briefly, but there's a lot of work in acceptance and commitment coping. And for chronic medical conditions, sometimes that's helpful to really work through and process and accept this is how life is right now. But that, and working toward your coping strategies to allow yourself to accept it, but not let it define what your life trajectory is going to be. And so I'm just, like I said, I'm just going to touch briefly on that. But I wanted to move into time management and prioritization, because I think it's a key factor when you're trying to fit in medical appointments, when you're trying to talk about schoolwork, when you're trying to do swim practice potentially, all these different things that are going on. How do we prioritize and how do we balance and help ourselves out? I often find in the chronic medical condition world that people are overscheduled or completely underscheduled, that they're kind of on extremes of this continuum. And our goal is to find a balance in that. And that balance may look different from when they're 3 to when they're 10, and it may look different from week to week to month. But trying to really reassess through that process and talking about want tos versus have tos. And so when I talk to teens or kids about priorities, it's not priorities. That's a hard word to define and to have that value established with it. But really thinking through that what is something that you have to do? And so a lot of times I hear I have to take my medicine, I have to walk the dog, I have to go to school, my parents make me. All probably true, but what is often missed is I have to sleep, I have to eat, and I have to exercise. So we often miss those very fundamental things, and when we think and when we're honest with ourselves, those are typically the things that get left out at the very beginning and that are the first to be pulled from. So the first thing, and I catch myself doing this, one of the first things to let go of my schedule is activity. But it oftentimes has to be some of the foundational things for our days. And thinking through what are have-tos, but also what are want-tos. What are things that you want to do? A lot of times kids will tell me that hanging out with friends or going on a play date is a want-to. Well, that socialization piece is actually really important, and I would argue at times that that's actually a have-to, because we know from an emotional state and from a fitting in state that that is equally as important as sometimes the doctor's appointments and everything else that's going on. And so we talked about all these active ways to cope with stress and to help kind of manage all these different things that are being thrown at you all and your families, but more of a passive way that oftentimes we cope, and we're all guilty of this at different times and in different degrees, but a passive way of coping when we often don't have emotional resources, physical resources, or cognitive resources is that we avoid. And that's okay. But what we need to understand is that avoidance cycle and what that contributes to and what that can lead to if we don't eventually address and use a more adaptive strategy and deal with the stressor in and of itself. So what often happens is there's a difficult situation, we get super stressed in whatever capacity. We avoid the situation at all costs, and we're like, whew, that feels better, so we're not so stressed. But the unfortunate thing is, and that we've all come in contact with, we're going to have to readdress the stressor, whether it's the next day, the next week, the next month. And what's happening in the background is that stressor is actually growing. And I think about it like as the Mucinex monsters, right? So like they're getting slobberier and that anxiety is growing. And all of a sudden it starts overtaking us. And so then when we actually try to confront the situation, it actually leads to less stress and we dealt with it. So I'm sure there's several examples that we can all come up with when we thought something, we made it super big, and then when we did it, it was way easier, and we're like, why did we wait so long to do this? Or why did we avoid this for so long? It was much better, whether it's going to get a biopsy or whether it's going to school after we've missed several weeks. But we talk about that avoidance cycle and highlight it because I think just the psychoeducation and understanding it at a baseline can help identify when it's happening. It's like, oh, I'm avoiding. Let me put a label to this. And sometimes we own it. Sometimes we're like, I'm not ready to take this on. I need to come up with more strategies. I need to sleep. I need rest. I need more resources. And that's okay. And like I said, that's not a bad technique. But what we need to do is then address it eventually and identify it. So then briefly, I know that we're getting close on time, but I wanted to go through and talk about the different role responsibilities in different relationships. And sorry for those of you that have little ones, but we can kind of amend it for the little population as well. But talking about like teens and the responsibility in increasing independent functioning. I think that it's hard, especially when you're living a very medicalized life, to have much or having sometimes a lot of oversight, but a lot of adults in your life. But even to say that, there has to be some independence there. And as parents, we've got to structure it so that they can independently manage this disease as well as their life in the future. And so when we talk through the different strategies, teen responsibilities are to follow rules, to learn effective and assertive communication needs. So oftentimes I talk about assertive communication in the 3 R's, whether it's refuse, rebut, or let me think, I could think of the third one right now. Refuse, rebut, or request. There we go. And talking about different ways that you can communicate with your doctors or with your nurses staff, allowing opportunities for them to speak, even the little ones can speak up in their medical appointments and talk about what is going well and what isn't going well for them. Gain increasing independence and effective management of medications, diet, balanced sleep. What I tell a lot of people is that I don't encourage complete independent management of medications until between 18 to 21 because I think it's hard. And the executive functioning piece or the frontal lobe isn't completely molded yet and developed. And so it's still having a little bit of a party. So if I had to choose between taking my medicine and going to a literal party, I'm probably going to go to the party because that's like right here, right now, and I'm not going to think about the future implications of not taking my medicine. So we try to structure that. We try to allow for space, but then there's reminders or there's check-ins with regards to that independent management. Maintaining balance and involvement in activities outside of the home, making sure that they have other outlets and other opportunities. And then to kind of follow up on that, appropriately addressing mood and talking about mood. And it's their responsibility to talk about if they're anxious, if they're stressed, if they're depressed, if they're sad, and to talk through that and to navigate that. Making a reasonable yet flexible schedule, so that's kind of that over or under schedule, and thinking about what can be pulled from my schedule if I'm scheduled from 6 a.m. to midnight every day, or what can be added to my schedule if I have a lot of free time. And then supporting and encouraging other family members as well, and trying to take other perspectives with regard to, this isn't easy for my parents, and it's not easy for my siblings as well. And trying to also take in all of the information from the family standpoint. The role of parents or caregivers in facilitating this independence is to support them, to provide opportunities for that growth and allowing that scaffolded approach to letting them manage some of these things. Meeting basic needs, as well as providing structure, kind of that foundational piece. And then setting and maintaining expectations and boundaries, as well as division of responsibilities. Having a chronic medical condition doesn't mean you can't do chores. It doesn't mean that you shouldn't be expected to do chores. Some things like that oftentimes we try to protect. Coping with a chronic medical condition is different than treating an acute illness in a lot of ways, but sometimes we parent the same. And so while parenting someone with an acute medical condition, we might try to completely nurture. No chores, you get to watch TV all day, you get to have all of your meals brought to you. But coping with and parenting with a chronic medical condition is a little bit different. We still want to reinforce that functionality and praise when it's able to happen independently. And then, let's see, the role of the parent guardian. Reinforcing teen in their independent behaviors and then promoting their family values as well. And so I often talk with parents about misguided support in this concept because I think at times as parents we really try to support, and again that distinction between how support is being perceived is important, but there is such a thing as that support sometimes can be off, and maybe we're doing something that we think that they really like, but in fact it's something that may be causing more distress or frustration for them. And so I often talk about, is this too much support or too little support, or are things okay? And so in the too little realm, the teen feels overwhelmed with too much responsibility, unsupported, invalidated, or misunderstood. Where in the too much realm, and I'm gonna jump to this side so I can see a little bit better, overwhelmed by too much information, believe they are incompetent and not able to handle any of this themselves. They are not strong enough to do this on their own, or they feel nagged, bugged, and harassed. And that's often a common one. And so sometimes just having this discussion, or even having them circle like, hey, this is what I'm feeling, or this is where this is falling right now, is a way to open up communication and talk about what would be more effective, or what would be more helpful, or what would you like this to look like. And I think that communication piece is huge. And then I said that I would briefly touch about school accommodations and things of that nature. We often find that schools, when asked, can be very accommodating. But there's such a thing as an IEP, which is an individualized education plan. That's more the academic realm, like if someone has a learning disability or a cognitive disability that we need to assess. But there is such a thing as a 504 plan. And this is something that's more medicalized and often comes with its own set of accommodations. And some schools say, oh, we don't need that. And what I often encourage families is to still seek this out or to still ask for it so that it's in the background, because sometimes elementary schools are great, but junior highs are not, or vice versa. Or high schools are great, but then if there's no accommodations moving forward in college, then we didn't set them up for success. And these can even be carried into colleges. And what we often find is that colleges are actually best suited because they get a lot of government funding for accommodations. And so talking through about whether or not your child just needs a simple accommodation for extended absences, that they may be missing school more frequently due to doctor's appointments and things of that nature, that they may need extended time to make up assignments, whether it's same day as the expectation or whether they need a day or two to make up assignments if they're being missed for doctor's appointments. And sometimes just providing some education, some medicalized information to the school about what are the symptoms, what is the condition, and it sometimes can help if that's in a formal document versus your child or teen having to reiterate or explain that in their elevator speech every single year to every single teacher. And so what I find is that oftentimes kids really appreciate having that so that it's already taken care of for them and not a barrier. Other things that sometimes can happen is that chronic medical conditions are not without pain. They're not without discomfort. We know from a research standpoint that that affects attention. So maybe they need extended time on testing. Maybe they need a quiet space or a less stimulating space to do some of those things. And sometimes maybe they need extra bathroom breaks, or they need to be able to take water or food with them. So those are all accommodations that can be fit and modeled to that plan. So then the next question I often get is, who can write those plans, right? So social workers, psychologists, we can all make recommendations, as well as your medical providers can at times help with that. A lot of times I encourage the schools to start that process and to send the paperwork, and then we can complete and fill that out. So that's all I had today. So I hope that was helpful. I know we have a panel, but if there's any questions, I have a couple minutes, I think.